So cardiomyopathy is a big topic. So we will divide into dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy in a different way. Today we will try to cover the whole dilated cardiomyopathy. So the cardiomyopathy classified into dilated cardiomyopathy, idiopathic cardiomyopathy, restrictive cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, unclassified and specific, like ischemic valvular cardiomyopathy, connective tissue disorder cardiomyopathy, like that. So dilated cardiomyopathy may be idiopathic, alcohol, infection, and infection. Like now, COVID infection also causes genetic peripartum cardiomyopathy, also considered as a dilated cardiomyopathy. Hypertrophic, you must be knowing that subaortic or apical or mid-cavitary problem is there. Restrictive, again, primary or idiopathic, there are amyloidosis, sarcoidosis, all these things are there. So type, this is the normal. First one is a normal thing, and second one is a hypertrophy. The muscle is hypertrophy. And third one is a dilated. It is almost dilated, and this is restrictive because diastolic dysfunction is there. Primary disease, intrinsic cardiac muscle, that is in cardiomyopathy, which I have told, dilated, hypertrophic, or arrhythmogenic, Takotsubo cardiomyopathies. Clinically, they present with a new onset of heart failure, arrhythmias also. Echo is very important, and we have to find out the etiology first, like valvular or congenital or ischemic or non-ischemic. Because echo will give you the systolic function, diastolic function, and filling pressure also. Any complication like MR or thrombus also we can find out by echocardiography. It's a global disease in systolic contractile function, that is a dilated cardiomyopathy, eventual dilatation of the ventricle. So echocardiography features in dilated cardiomyopathy are all the chamber, most of the chambers are dilated. So LV, LA, RV, RA are dilated. Usually, normal wall thickness, that is all are dilated. Mainly dilated is the main important. So, what are the causes? Idiopathic myocarditis, ischemic heart disease, infiltrative disease, peripartum cardiomyopathy, or patient is having hypertension, connective tissue. These are the main causes of dilated cardiomyopathy. 2D echocardiography, the spherical dilatation, the LV is totally dilated. Normal reduced, the EF is reduced. But the wall thickness is normal or reduced wall thickness little bit. Ischemic cardiomyopathy, wall thickness is reduced. Dilated cardiomyopathy, wall thickness may be normal. So poor systolic wall thickening, reduced inward myocardial function. Okay. And all the systolic indices are reduced, including LV fractional shortening, fractional area changes, ejection fraction. All these things are reduced. And all the four chamber, which I have told, is dilated. So 2D echo, what you will get? Dilated LV, dilated RV, dilated aorta. Left ventricular ejection fraction is reduced. Right ventricular also sometimes it is reduced, but normal wall thickness. This is very important. So what you get in M mode, dilated cardiac chamber, that is E point, that is very E point septal suppression, EPSS. Normally EPSS is less than 7. If more than 7, then it is a LV function reduced is a ejection fraction. More than 17 considered to be severe LV dysfunction. So 2D echo, what you will get? M mode, what you will get? M mode, you can see EPSS. So Doppler findings, what you will get? Diastolic dysfunction, and initially impaired relaxation, later restrictive pattern. Almost most of the cases, 90% of the cases, you will get the mitral regurgitation. This is because of annular dilatation. And apical tethering or leading to restrictive. So mostly you will get the MR. So this is how you echocardiography. The chambers are dilated, LA is dilated, aorta is dilated, LV is dilated. Okay, so this is the aorta ventricle. The EPSS means E point. This is this point to this point. If it is less, then good LV function. If it is more, then it is a severe LV dysfunction or LV dysfunction, EPSS. And this is the dilated chamber. If you see the LV is a 6.6. It is almost dilated. So normally 5.5, it is the normal and it is dilated. If you see the aorta also, it is dilated. RV is dilated, left ventricular. So this is the M mode cut, two chamber with the plaques view. And this is the again M mode where the EPSS and the LV is dilated. So this diagram clearly shows that the patient is having dilated cardiomyopathy. Again, the RV is dilated, LV is dilated. If you see the RV, the RV is dilated, you have to see from the base, you have to see from the RA. So LA is dilated, LV is dilated, and EPSS also, you can see the tissue Doppler also, tissue Doppler is also. So mitral inflow, diastolic dysfunction is there. MR will be almost, this is the MR will be there, annular dilatation is will be there, and dilated chamber, MR will be there. This is the MR. And if you see the E prime mitral inflow promise impaired diastolic dysfunction will be there in dilated cardiomyopathy. Reversal of AE, that is A is more than E, so diastolic dysfunction will be there with a prolonged deceleration time. This is also one of the important features. Long axis dilated chamber, almost more than 6, it is the dilated chamber. That is and LA is dilated, aorta is dilated, RV is dilated. But the thickness is preserved. Dilated cardiomyopathy, these are the dilated, how it looks like. Okay. So if you see the aortic valve also, aorta is also dilated. Grossly, the RA is dilated, RV dilated, LA, but the thickness of the is LV or RV is preserved. M-mode echocardiography, which already we have discussed, the LV dimensions are more than 6 here. So LV dimension 6.2, 6.3. EPSS is very high. EPSS, that is very, very important in LV dysfunction ejection fraction. So M mode increase separation of the mitral leaflet E point from the septum. So the EPSS is very important in M mode also. Then you can find out from the left ventricular volume, how much it is the left ventricular volume, 2D echocardiography by Simpson's formula, and you can find out the EF, how much is the EF. So end systolic volume index is a very, very important because it provides important information in severe clinical setting. That is a very important. In end systolic volume index, that rises progressively from normal is less than 31 in men and less than 24 in women, is an important clinical indicator deteriorated global function. So end systolic volume index, you can get it in the computer also. Patient with ischemic cardiomyopathy who have a global dysfunction with segmental evidence of the infraction, that is RWMA, and systolic volume index of 45, identify patient is having poor outcome. Prognosis also very, very bad if the end systolic volume index is high. In the later, this is not required. Okay. So how you look like the non-ischemic cardiomyopathy or dilated cardiomyopathy, the LV is thickness is preserved. All the chambers are dilated. So RA, RV is dilated, LV is LV. This is dilated. The main important mitral regurgitation is the annulus. Mitral annulus means from here to here, it is wide because of LV is dilated, annulus also dilated. Because of annulus dilatation, MV tethering, because of MV annulus is dilated, MV tethering is there. Dilated cardiomyopathy, very important thing you have to understand is all the chambers are dilated, ejection fraction is low, the mitral valve annulus is dilated, EPSS is high, EF is low, heart pumping action is low. So mitral regurgitation, this is altered LV geometry because LV is so much of dilated. The annulus from here to here, if you see the annulus diameter is high. Because of annulus is high, there is a gap between the MV mitral valves. So annular size increases, decrease in closing force. If this is dilated, this is constant, this is dilated, so there is a gap. If this is this, then we can find out the prognosis if this patient is little poor. Sometimes you may get apical thrombus in the dilated cardiomyopathy because ejection fraction also very low. When ejection fraction is low and RA-RV is also dilated, you may get a thrombus. Okay, if you see the contrast enhancement, these are the contrast, but because of this is the thrombus, you may get like this. So this one patient we have taken, so this is the thrombus. Okay, so if you get a picture like this is apical thrombus, and this is. So echocardiography prediction, LV size and function, RV involvement is there or not, RV dysfunction is there, TR is there or not, TRPG how much, you have to find out. LV size function, LV is how much dilated, if it is more than 5.6, 5.8, 6, 6.2. So the more the LV dilated, the prognosis is bad. RV function, dysfunction, that also you have to see. Diastolic dysfunction is there or not, you have to find out from the echocardiography. So best predictor for the death in a symptomatic patient, the prognosis is bad in diastolic dysfunction also. The ejection fraction is less than 25. Deceleration time is less than 130. Mortality in 2 years of 65% versus 26%. If the deceleration time is more than 125, then it is mortality is more. So deceleration time, ejection fraction, diastolic dysfunction or decelerating time will come in diastolic dysfunction. So LV filling pressures and LSI is also dilated or not. So in that, this type of patient, when ECG if you take, if it is a LBBB pattern or a RBBB pattern with QRX is more than 140, then CRT is indicated, one of the procedure for the cardiac.